The only reason payers exist is to manage risk. That's what insurance companies do by definition.
Welcome to the Healthcare Grind, where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Harthcock, and I'm joined by my co-host, Lon Hecht, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Good afternoon, everyone. Welcome to the Healthcare Grind. It's great to have you back again today. My name is Lon Hecht, and I'm with my co-host, Jess. Jess, say hello. Jessica Harthcock, by the way.
Hey, everybody.
It's great to see everyone again. We have a fantastic guest this afternoon. We have Erik Johnson, who's the SVP at Optum. Erik was actually brought on by Optum to start their value-based care practice. And today we're going to talk about all things provider, which is kind of our theme. We're walking through different areas of healthcare. So, Erik, do you mind doing a quick intro on yourself, maybe a little bit of background?
Sure, be delighted. Erik Johnson, Vice President for Value-Based Care at Optum Advisory Services. I've been with Optum about 9 years. Been a healthcare consultant, primarily with providers, for about 27 years. And I live and work out of Washington, D.C.
Awesome. Well, thank you so much for joining. I've had the great privilege of working with Erik. I spent about 3 years at Optum. We work closely together. He's fantastic, just plethora of knowledge. So it's great to have him on the show. So, Erik, I figured we'd start off. When we're talking about providers, people tend to think of your primary care physician, right? But provider means so many different things to so many different people. I figured I'd kind of flip it over to you and say, when you think of providers, what do you think about? And can you kind of give us some high-level ideas of the different areas that people should be thinking about? One thing I'll say is, once again, our audience tends to be early-stage healthcare founders, healthcare executives, and also investors. So maybe if you could wear that lens, that'd be great.
Sure. I think of providers in two really big categories, and then we can sort of double click on those categories if you like. But the first category are providers who take ownership of a patient for some part of their journey through the healthcare system. So that could be primary care physicians who own the life, if you will, at least a year in the life of that patient's membership eligibility. I think of health systems and hospitals as owning the episode of care when somebody is admitted. And then I think of specialist physicians as physicians who own a patient for a particular procedure or a particular condition. So think a cardiologist or an endocrinologist or somebody who is specialized on the disease. So that's kind of the first tier, providers who take ownership of a patient's journey or a major section of their journey through the healthcare system. Then there are the second class of providers, not that they're secondary class, but the second type of providers are folks who receive patients as part of that journey. So think about pharmacies, labs, home health, skilled nursing facilities, which kind of cross the boundary between those two, because a skilled nursing facility or a home health agency, for that matter, might take responsibility for that patient for 30 or 60 days. But I still tend to think of them as receiving the patient. And I think of that first category as owning the patient.
That makes sense. Then when you kind of level up, you hear all these terms, things like ACO or multi-specialty group or IDN. Can you talk about, or hospital or health system? Can you help make sense out of that for us and for the audience?
How much time do you have? Because it's a tricky knot to untie. Let's start with ACOs.
Sounds good. Why don't we pick a lane? And that sounds like a great one to start with.
Sure. Because I think this is a major dynamic that we're seeing in healthcare today, which is collaboration across different types of providers. And the accountable care model came out of Dartmouth back in 2007, 2008, and then was adapted by CMS as a result of the Affordable Care. The Affordable Care Act put a premium on the development of accountable care organizations. So what are ACOs? And they are intended to be collaborations between different types of providers who are attributed to patients for whom they take responsibility. So a good ACO is going to be denominated by primary care physicians who own the life, specialist physicians who are going to be able to treat those patients for the type of care that they need for their disease or their condition, and health systems who are going to have to do the heavy interventional work if these episodes actually evolve into acute care episodes. an ACO ideally looks like that. And it is built to encourage collaboration, information exchange, care coordination models for a bespoke body of patients. And for the most part, that has been Medicare, the over 65 population. So an ACO isn't a provider. It is a consortium of providers that include both those primary and secondary providers that I talked about earlier. And that is kind of the coin of the realm. Right now, ACOs have become very popular in the last 12 years since they first went live with CMS. When you break down those collaboratives, you have different types of hospitals. You have community-based hospitals, which most people are familiar with. You have academic medical centers that have a teaching and research mission and have very high overhead expenses associated with that research mission. So they don't tend to be a low-cost provider and aren't always a great fit for an ACO, which is looking to manage costs. You have integrated delivery networks, which are sort of health system denominated, but also have integrated either owned or affiliated physician practices and clinics into their organizational model. So they really are positioning themselves as an integrated delivery network to own as much of the patient journey as possible. They are also in a good position to manage not just the journey, but the total cost of care associated with that patient's journey.
Gotcha. That makes a lot of sense. So when you look at an ACO, how does a patient or a member get attributed? How do they end up in that ACO? How does that work?
It's a claims-based mechanism. So what will happen is the convener, if you will, of the ACO, whether it's CMS or a large health plan, whether that's Cigna or United Healthcare, will look at the claims associated with their members and identify what they call E&M codes. It's evaluation and management codes for each of those patients. Those evaluation and management codes tend to be documented by primary care physicians. And the primary care physician who documents the most E&M codes is attributed that patient. That doesn't always work. For example, if you are an oncology patient, a lot of your E&M codes are going to be done by your oncologist simply because that's the physician you're seeing the most. But you can also attribute that way, but primarily it's attribution from primary care claims to primary care physicians. And then that physician or physician group is notified that they are now, quote unquote, responsible for Jess or Lon or Eric.
Is the member experience any different for the patient? Do they know that they're a part of that ACO? If so, how is it better? Are there any downsides of it? Can you talk to us about that?
It's a big question. If they're part of a Medicare ACO, they are supposed to know. They're supposed to get notified by CMS that they are part of an ACO. Their experience should be different. The whole idea of the ACO is to create a different experience for the patient. Their care should be better coordinated. They should have greater visibility into where they're being referred. They should get a higher quality of care because that coordination is actually taking place. They should know sort of what ecosystem they're being treated in, and they should be getting better outcomes as a result. That is not always the case. The ACO model is really a Kaiser-like model watered down tremendously. That's not to say it's not always effective, because it can be, but it really depends on the power of persuasion of the members of the ACO to convince the patient that they're getting better care as a result of their membership in the ACO than they otherwise would be. But it doesn't have the same binding that membership in a insurance product has. It's meant to replicate that, but at a much more sort of diluted level.
That makes sense.
So if you're somebody that's selling to an ACO, is it a similar process as it would be selling to a payer? Should you think of them aligning closely to what a sales process to a payer would look like?
Yeah, and this is where you're starting to tread on my value-based care terrain, which I can, as Lon can attest, I can talk about for hours.
And you are welcome to.
I will try to be somewhat concise. Yes, the answer is yes. If you're selling to an ACO, you are selling to an entity that bears and manages risk, just like a health plan does, just like a physician group that is taking fully delegated capitation payment would. It's a different degree of risk, but it's not a different kind of risk. And so selling to an ACO would emphasize things like total cost of care, patient experience, quality outcomes, efficient delivery, and efficient allocation of the site of care. It's a lot of the same themes that you would use in selling to a payer, because a payer is just another risk bearer in the grand scheme of things.
Well, you just brought up something else, and we can pivot there next. You talked about physician groups taking on capitated risk. So a big move that you're seeing by a lot of the payers now is they want to push that risk out as best they can. And you're seeing that happen, Optum being incredibly successful in that particular business. So can you talk a little bit about what that looks like from a provider perspective? And if you were an early stage founder, how you would think about selling to them? Would that be another channel? Would you be thinking about them in the same light as going after a United or a Cigna or an Aetna or a Humana? Would you also be looking at the big physician groups? And is it a very similar sale?
It's similar, but not the same. The movement towards delegated risk is an important one, and I think there's a lot of nuance to it. I'll tell a story about a panel I was on. This was many years ago. I was representing the provider industry in this world, health systems in particular. There was a Blue Cross plan representative on that panel, and I think there was a physician on that panel representing docs. And during the course of that panel, the Blue Cross representative said during the course of his remarks, "We hate risk. We just hate insurance risk," during the course of his comments. And I was sitting there thinking, the only reason payers exist is to manage risk. That's what insurance companies do by definition. So after the panel was over, I went up to him and I was very nice about it. I just said, I'm kind of curious about that statement that you made about hating risk. And he said, well, what we're good at as a payer is pricing risk. We have all of the actuaries in the world. We know how to price risk really well, but we're terrible at managing risk because we have members, but physician groups have patients, and the risk is managed at the patient level. It can be measured and priced at the member level, but it's managed at the patient level. So this movement towards delegation that UHC is doing with Optum, that a lot of private equity-backed physician groups are doing across the country, what Amazon is interested in, what Walmart is interested in, is managing that risk as close to the patient encounter as possible. And if they're going to manage that risk and they're going to do it successfully, then they should be rewarded for creating that value under the premium dollar. And what's happened historically is that if they were good at that, they did create value, but it just rose back to the payer. Now they get to keep that value. And that's a tectonic shift in the way care is thought about, measured, coordinated, and managed going forward. But it is hard. There's a mindset change involved in that. Owning the life is different than owning the episode. It just is. You're going to be measuring different things. It has profound implications for your balance sheet and your income statement. But the fact of the matter is, in healthcare today, particularly in Medicare, especially in Medicare, the margin is in the risk. The margin is not in payment rate or the episode. So if you want exposure to the margin, you have to have exposure to the risk.
Makes a lot of sense. It's funny that you say that about the executive from Blue Cross Blue Shield plan, because when I think of payers that have moved to shifting risk out closer to, to the patient or to the provider, they're not ones that come to mind up front. They tend to, maybe I'm wrong, but they seem to be a little bit behind the Uniteds and the Humanas and others that seem to be pushing more and more risk out, and maybe Aetna and some others. Has that been your experience as well?
Yeah, it has been. And I think that's slowly starting to change, but I think the market and competitive forces are forcing that on the Blues plans because the investor-owned plans view delegation. It's a little bit of a relay race. Getting a good delegated model in place should drive down cost of care. It should. And generally, well executed, it will. If you drive down cost of care, you have a more competitively priced insurance product on the marketplace and you can grow. And so the Wall Street emphasis on growth in all these plans is going to be driven quite a bit by your ability to put a competitively priced product on the market. And delegation is seen, and I think accurately seen, as a way to get to affordability.
Mm-hmm. A couple questions I have for you, Erik. So if I'm a young startup company, how am I kind of parsing through opportunities? Where should I start in this space? Are there different areas that come to mind, even geographical regions that maybe, for example, up east, they have some different type plans that maybe are managed a little bit better than some of the plans in the South. But if I'm a startup, where am I thinking about going to try and get my product into some of these different entities?
Can I split that question into two answers? Or at least two opinions?
Hey, you're the guest, Erik. You can do anything you want. You have a lot of power here today.
Outstanding. I love it. The first place I would focus as a startup founder is in the Medicare Advantage space. That is where all of the activity is happening. Not just Medicare Advantage, but Medicare in general, Medicare Advantage in particular. That has proven to be a very fertile market for innovation, I would say, not just in risk, but in the use of remote monitoring. I think in the use of new care models, certainly in the world of new contracting models. I think there's a lot of innovation in the way payers and physician groups or IDNs are contracting for risk. And the population is getting older. So just from a sheer numbers perspective, there are more bodies in Medicare every year than there would be in, say, employer-sponsored health plans. So there's a market demand for that. We'll talk about some of the headwinds there in a second. So from a product standpoint, I'd be focused first, but not exclusively on Medicare opportunities. From a geographic perspective, that's a tougher question, Jess. Plenty of people are going to disagree with this answer. Okay. But I would look at places like Northern California and Southern California. I would look at places like New England. I would look at places like the Mountain West, the Pacific Northwest. And I say that because there are big, dominant managed care plans in those marketplaces, which create all sorts of competitive catch-up pressures on everybody else. So everybody in Northern California is competing with Kaiser. They need solutions in order to compete with Kaiser. The same is true in a place like Utah, where everybody has to compete with Intermountain Healthcare. So when you have sort of this big behemoth that is establishing de facto market standards of excellence, everybody has to meet those standards of excellence, whether it's in risk management, whether it's in quality, whether it's in patient access. And everybody else who's not part of that network has to catch up with the market leader. Now, plenty of people are going to disagree with that. Plenty of people are going to say the bodies that litter the ground in Northern California, people who try to compete with Kaiser, are stacked up. And that is true, right? But we know what the rules of engagement, we know what the rules of competition are, and there is always a hunger for an alternative. And that's why I think looking out for those dominant payers, those markets that are dominated by those types of payers, end up creating lots of market opportunity for startups or even establishment.
Yeah,
Erik, I want to say, I think you crushed that. I think you crushed that answer personally. What were you saying, Jess?
I mean, it's a fantastic perspective. One that I actually have not heard, but the way you positioned it, excellent. I think that's why you see some of the incubators out there. I mean, Kaiser has an incubator, and it's because of all the other incubators surrounded in that area. I mean, it's a hub for startups. And so what a great way to be out there and be able to position it against some of these larger folks that seem to be winning.
Well, I feel like if you want to be the best, you got to beat the best, right?
Yeah.
Right. If you want to do that, and that's where innovation happens. So I thought that was great. So, hey, Jess, if you don't mind, I kind of want to pivot a little bit, right? I want a little alphabet soup here. But when we get to the more of the true provider side of things, and we start thinking about like health systems, you hear about, IDN and CIN and FQHC and different things like that. So I'd love to spend a little bit more time in this episode kind of talking about that side of the provider model, what those different things are, and then things that startup founders should be thinking about that are critically important to them. Because what's important to a provider is probably different than what's really important to a payer. There's some similarities, but there are going to be some differences. So I'd love to talk a little bit about that. So why don't we start off with, some of these different models, IDN, CIN, things like that. Can you help make some sense of that for the audience?
Sure. So I think I mentioned earlier, IDNs tend to be denominated by the health system that anchors the network, but it is a network. So an IDN is a network anchored by a health system in a particular geography. But what's integrated into that network are physician groups that are, again, anchored in primary care. Mm-hmm. Today, what we've seen is a lot of scrambling to get a lot of primary care physicians into that network because they control the lives. That means they can control referrals. But that also includes certain types of specialties. Certainly, oncology, cardiology are big specialties that need access to facilities. They need access to capital. They need access to ORs. And so they are natural folks to bring into an IDN. Labs are also generally part of that. So hospitals can capture the lab revenue as well. And most hospitals have their own pharmacy. It tends to be a little bit more expensive than the Walgreens or the CVS down the street. But that's really what an integrated delivery network is. Trying to own as much of that patient journey as possible. A CIN is a little bit different.
Before you go there, so
sure.
Can I just ask a question on the IDN? So does the IDN contract as an IDN with a payer, or do the individual hospitals and providers in there try and contract individually on their own? How does that contracting work?
The answer is yes. It can be either
one. It's always simple like that.
Yeah. But that's where you're getting into something like a CIN, which an IDN can be part of. And the clinically integrated network is established to do exactly that, to take disparate, related stakeholders in the marketplace, physician groups, labs, maybe a hospital. They're not necessarily owned by the same corporate entity, but they establish a legal entity called a clinically integrated network. And in order to qualify for that legal designation, they have to promise to do certain things around information exchange and information sharing. They have to do certain things around care models. So it looks like we have a care model in place, but ultimately the goal of the CIN is to consolidate the contracting on behalf of that group of stakeholders. And that may or may not include a health system. It may or may not include a skilled nursing facility or a home health agency, depending on what you want to contract for. If you're contracting for Medicare, you want post-acute care providers in that network. If you're contracting for Medicaid, you probably want to over-index on maternal and child health and maybe behavioral as part of that CIN. So the CIN is really a contracting vehicle that has option value on it. The main thrust is the contract, but the CIN can also serve as a platform for acquisitions. It can serve as a platform for growth, and it can serve as a platform for risk management.
Makes sense. What about FQHCs? You hear a lot about that, but I feel like that's an area that folks don't truly understand a lot about. Can you talk a little bit about what they are and how they, maybe if you don't mind touching on how they get paid? Because I think that's an important thing for folks to understand.
Yeah, so an FQHC is a federally qualified health center. And they take different flavors. You can have a federally qualified health center that focuses only on dental. You can have a FQHC that has a full range of offerings that includes primary care, a little bit of ambulatory surgery, dental, some behavioral health. They get paid and they serve primarily folks in urban areas or underserved areas, probably a better way to think about it, because there are plenty of rural FQHCs out there, but they serve underserved geographies, underserved populations. Their payer mix tends to skew towards self-pay or Medicaid, and they get paid by Medicaid, generally under a fee-for-service arrangement. They also do fundraising on their own, just like health systems do. They're looking for federal grants and local grants as well. So they tend to be a little bit more deprivation focused in the types of services that they offer. They tend to integrate a little bit more solutions to social determinants of health and efforts to mitigate health inequities in particular markets. And they do end up competing with urgent care clinics, which is sort of a cousin of an FQHC, but doesn't have the same charter as an FQHC. So a federally qualified health center is going to have certain requirements that they need to meet in order to retain that designation. And that designation gets them access to discounts on drugs and other supplies.
Gotcha.
Who is doing this well? I mean, is there someone in all your years of doing this that stands out in your mind that kind of makes you say, you've got a fantastic model, you have figured this out?
There are lots of folks out there who are doing it well. But you know what's interesting? What seems to me, at least, to be driving most of the innovation now is necessity. So I have a client in North Philadelphia. Philadelphia is one of my favorite cities in the country, but North Philadelphia
it's where I grew up. Shout out to Philly, Eric. That's where I grew up.
Shout out to Philly. Love Philly. But North Philly, Lon, as you know, is a little rough. And my client up there served an uninsured and Medicaid covered population for 80% of their patient load. Just to keep the doors open in the hospital, they had to manage ED arrivals, right? A lot of people are using that ED not just for primary care or non-emergency care, they're using it for shelter. So that health system, I thought, really got ahead of the game in their population health investments, getting out in the community, using the CIN that was affiliated with the health system to really start to address some of the social determinants of health, partnering with the FQHCs in that part of North Philadelphia to sort of refer demand to a lower cost, frankly, more accessible site of care for those patients. And they weren't doing it because they were trying to be Kaiser. They were doing it because that's how they were able to maintain an operating margin that allowed them to stay open, right? And so I've always joked that the best practitioner of health equity interventions would never call it health equity. They would call it population health, just because that's what that population needed in order to stay healthy. Now, they were doing health equity work, but that's not the way they thought about it. So that's one of them. I can give you the usual cast of suspects. I think Kaiser does a really good job at this in Northern California. They've been doing it for 80 years. That model started in the shipyards during World War II, and they've just evolved it over time. I think Geisinger has done a really good job. That's why they're paired up now. Kaiser and Geisinger do have a lot in common. Group Health Pacific Northwest used to do it really well. They got purchased by Kaiser a few years ago, but that's the system that I grew up in Seattle. I grew up in Group Health Puget Sound, and I thought they had a great model. And, I don't want to be accused of being a homer here, but I think Optum Care does a great job at this. I think they've really figured out how to manage their panels as effectively as possible. And they don't just do it through coding. Like, I've talked to enough of the physician leaders at Optum Care to know that they really are very intentional about who they partner with, how they manage referrals, what they're doing in order to get that patient to the right side of care with the highest probability of a good result. They do it really well in a lot of their markets. Not all of their markets, but in a lot of their markets.
I would agree.
That's great. Yeah, me too.
So, question for you: Are there any provider? I know we're kind of getting a little bit later in the episode here. Are there any kind of provider groups that you feel like I should call out? I mean, you mentioned urgent care. There are freestanding ERs. Anything else that you think needs some time that we should devote to for an early stage founder that they should think of?
So you said freestanding ERs, and it just gave me a tick, because the freestanding ERs drive me crazy. But that's not the subject of the
Do
podcast.
Tell.
Yeah.
Another episode on freestanding.
Yeah, it's another episode. I think post-acute care providers is something we haven't spent a lot of time on. And
that's a good point. You mentioned them a little bit at the beginning.
Yeah. As the population ages, they're becoming really important parts of that care continuum. And it's partly because historically, the care delivered in the post-acute care setting has been unmanaged. It's been sort of what I would call a pure fee-for-service driven environment with no constraints on volume or length of stay, really. That's coming under greater scrutiny now. And they represent a terrific opportunity, not just to save money, but to improve the outcomes that patients experience after surgery or after an acute care discharge. The challenge that they are having right now, as I'm sure you know, particularly in the skilled nursing world, but also in inpatient rehab and long-term acute care hospitals, is a labor crunch and a perception that they were a hotbed of COVID infections in 2020, which they were, but they couldn't help it, right? That those are residential environments. And that is a high-touch, model of care that you cannot substitute remote monitoring for. So between the pandemic and the labor shortage, those types of providers, particularly skilled nursing, are really looking for innovation in how they can staff and deliver care in a way that is attractive to patients, is also attractive to their referral partners, which by and large are going to be discharge nurses at health systems. It's a really, I don't think it's a very well understood part of the care continuum, but it's incredibly important, and it's only going to get more so as the population ages.
That's a good point. I'll just call out home health as well. We don't have to spend a lot of time on it, but home health, I feel like, is a critical area and definitely a shortage of providers. I just read an article that something along the lines of 75% of discharge requests to home health are getting turned down. I mean, it's that the shortage is that severe. So that's another area that needs a lot of focus from an entrepreneurial perspective on how to fix that. One thing I did want to ask about quickly, because you mentioned it, information exchanges, how that information is shared on the provider side. Could you touch on that? I mean, that's not a quick subject, I get it, but could you give it the old college try to help the audience understand in a minute or two what's going on that side and why that's important?
In a minute or two?
I didn't mean to time bound you, but I just did a little bit. Sorry.
Sure. So I think the industry is finally getting the equilibrium right on this. 15 years ago, information exchange was a big deal. The technology was not there at the time, and frankly, the payment models weren't there. So it was a little bit of cart before the horse. Since that time, industry standards have emerged that make the transition to a pure health information exchange model across different platforms a lot easier. It's not easy. I don't want to suggest it's easy, but it's getting easier with the FHIR standards, FHIR, if you're not familiar with them, are standards industry approved that govern sort of the exchange of information from, say, an Epic EHR to a Cerner EHR. That's technical, right? That's an engineering problem. And it's kind of like math. You can do the math, right? It's kind of like, it's kind of like lyrics. Like, I'll learn the lyrics to the song, but I need a tune. What was lacking was really a melody. And now with the evolution of payment models, there's actually a melody that you can put these lyrics to, that there is a reward potentially in the payment models for providers to exchange data efficiently and rapidly. And I think that is, we kind of got there through the back roads, but we got to the right destination now. And I think we're just going to see a lot more information being exchanged between providers going forward.
That was really great in a short period of time, so we really appreciate that. We're going to wrap in just a couple of moments. Jess, is there anything that's burning for you? I know sometimes you have a question that you're sitting on.
No, Erik, it's been, I come from mostly the payer space. And so this has been really interesting and a learning experience for me, just listening to you talk and different areas to explore. So you've been fantastic. Thank you.
Yeah, Erik, great job on this. How can the audience get in touch with you if they want to?
Sure.
And by the way, Erik is always available for consulting. He's fantastic at that. Keep that in mind. That is his background. But go ahead, Erik.
You can try to find me on LinkedIn, but as I was telling Lon and Jess earlier, Erik Johnson's a pretty common name. I might be tough to find. But good luck. Try to find me on LinkedIn. Otherwise, you can find me at my email address. It's Erik, E-R-I-K, period N as in Norman, period Johnson at optum.com. So that's Erik.N.Johnson at optum.com.
Erik, we really appreciate it. You've been fantastic. So if you have an opportunity, everyone, please hit subscribe. And if you want to get some more advanced content, please go to healthcaregrind.com. And thank you again for another great episode. Everyone, have a great day.
Thanks, Erik. As we wrap up this episode of the Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from the Healthcare Grind.